Okay. So, coronary cardiogenic shock. Any other questions on coronary or non-coronary cardiogenic shock? Okay, so just to briefly recap, cardiogenic shock is about the heart's ability to pump. And yes, it is a bit confusing, but it's about really identifying what's happening in the body. And one of the things that I will say to you constantly, and certainly when I teach you, if I teach you in the third year, I'll talk about understanding the pathophysiology, because if you understand what's going wrong in the body, your symptom management and assessment criteria will change, and you will be able to clearly identify what's happening and what's going on. So the difference between coronary and non-coronary cardiogenic shock is whether the issue, the problem, is actually in the heart or outside the heart. So if we're talking about something that's going on in the heart, we might be talking about a myocardial infarction, we might be talking about a valve problem, we might be talking about an electrical problem such as AF, but equally, if we're talking about non-coronary cardiogenic shock, we're talking about things that are going on outside the heart. They're going on outside the heart, but they're still having an impact on whether the heart is beating appropriately. So what's the cause of the problem? Yeah, I suppose coronary cardiogenic shock would be slightly more common than non-coronary, but we need to still be aware of the two. So I've covered what's going to happen to the blood pressure. The blood pressure will go down, but it won't go down as dramatically as in hypovolemic shock, and the levels, so the diastolic and the systolic, the gap will close. The pulse will go up, but it also might change in its nature, i.e. its rhythm, its rate, its how it feels. So if your patient's going into AF, the beat will become irregular and erratic. O2 saturations, PO2 levels will change dependent on the cause. So if the patient is, the cause of the cardiogenic shock is non-coronary, caused by pulmonary edema, for example, then the chances are the O2 saturations will drop very quickly. I don't use the term heart attack because that's not a clinical term. What I refer to is a myocardial infarction. So this is where part of the heart muscle has died, and that is coronary cardiogenic shock. A heart attack is what people in the general public talk about. So I don't refer to heart attacks because that's not what they are. Okay, so I hope that answers your questions. Any other questions about coronary or non-coronary cardiogenic shock? Okay, I'm going to move on to the next one. And if you thought cardiogenic shock was complicated, this one probably is even slightly more complicated. And we're talking about here distributive shock. When we talk about distributive shock, we are talking about a number of different types of shock, which include septic shock. So when a patient has become septic, we're talking about neurogenic shock. So where they have a neuro injury, so something wrong with their spinal cord. Or we might be talking about anaphylactic shock. So anaphylactic shock being a severe allergic reaction. Because what we're talking about in all of these is not a loss in volume, and it's not the heart not being able to pump, it's a massive shift in volume. So the volume that should be going around the body has gone somewhere, gone to a specific place, and it is no longer available to be circulated around the body. So what might be the causes of, for example, that massive shift in volume? That is caused by vasodilation. So all of our vessels in the region that's been affected, so if it's neurogenic, it's going to be the spinal cord. If it's an anaphylaxis, so for example, a bee sting, and one area of the body has swollen up massively, that is a shift in fluid. So the fluid is dramatically travelling to the area that's affected. If the patient is septic, then that shift of fluid is out of the blood volume and into all of the lymphatic system, if the patient has become systemically septic. So the volume hasn't been lost, and it's not that we can't pump it, it's just it's been redistributed, which is why we call it distributive shock. So we've got a shift in volume, vasodilation. Now, because the vessels all over the body have dilated, then there is, again, a reduction in venous return, a reduction in stroke volume, a reduction in cardiac output, and then a dramatic reduction in tissue perfusion. So again, the pulse is going to go up, the blood pressure is going to go down, the respiratory rate may increase. The thing that you will notice with distributive shock as a key difference is that your diastolic volume, your diastolic blood pressure, that's the bottom measurement, which talks about peripheral resistance, goes down very dramatically and the gap widens. So although your systolic blood pressure will drop, because you've got a reduction in stroke volume and you've got a reduction in if you've got a reduction in stroke volume and you've got a reduction in cardiac output. So your systolic measurement will go down. Your diastolic measurement, i.e. talking about peripheral resistance, because there is a shift and there is a massive vasodilation, that measurement will go down even more. So the gap with your blood pressure will widen. Is there a, I think we might have had a few typos there. Is there a type of, if again, you're talking about a stroke, you will be talking about a cerebral vascular incident or event, and that that comes under the classification of a neurogenic injury. So distributive shock covers anaphylaxis, sepsis, and neurogenic shock, and that's where you've got a shift in volume. You haven't lost it. So one of the key things that you've got to think about when you're managing patients who are in shock then you have got to think about, for example, if you're going to start some intravenous fluids, in a patient with hypovolemic shock, you want to put lots of fluids in quickly because you want to replace that volume. In cardiogenic and anaphylactic shock, putting lots of fluid in quickly is not going to alleviate the situation in quite the same way. So we might need to be very careful about the amount of volume we put into a patient who is septic or who is suffering from cardiogenic shock. Because if you put lots more volume in and you haven't solved the problem itself, you're not going to alleviate the symptoms of shock and therefore successfully manage your patient. So sometimes we jump in and go, if they're in shock, we're going to start fluids, we're going to bump up fluids. That's not always going to help. So yes, with an anaphylaxis, if your throat swells, for example, you've eaten a nut and your mouth and your throat and your your mouth, your lips and so on will swell, that is a dramatic increase in the amount of volume that has arrived in that area. And that causes distributive shock. Septicemia, sepsis, septic shock, a patient becoming septic, they're all much of the same term. Septicemia tends to refer to a condition that is systemic and involves the blood itself. If you are referring to somebody becoming septic, you will maybe suggesting that they have septicemia. So these terms are almost interchangeable. Just have to make sure we understand exactly what they mean. Any other questions? So we've got 3 different types of shock, which will have subtle differences in their presentation and therefore require differences in their management. Because in distributive shock and in cardiogenic shock, we need to solve the problem before we can successfully manage the patient. In hypovolemic shock, we might have to quickly replace the fluid and then adjust our management. So what happens to the pulse and the blood pressure in distributive shock? Again, the patient becomes tachycardic, but you won't necessarily have any kind of change in the tempo, pulse, or type of shock. You have lost my train of thought. So your pulse will go up, but you won't have that change in rhythm like you would do in cardiogenic shock. Your blood pressure will go down, but remember, we're going to look at where our systolic is in relation to our diastolic. It's not just that the blood pressure is generally going down, it's what's the gap between the two. So the diastolic will go down far more dramatically than the systolic. The systolic will go down, but not as dramatically. Are there any other symptoms of distributive shock, or would all 3 types of it present slightly differently? All 3 types will present slightly differently because their cause is slightly different. So, for example, with sepsis, septicemia, septic shock, we might have a change in the temperature. We might have a clear indication of the site of infection. With anaphylaxis, it's a profound allergic reaction, so we may get some localized swelling. We might have a very specific reaction that we can visually see. So it's going to be down to our assessment. With neurogenic shock, it's about a neurogenic injury. So either a spinal injury or maybe a cerebral vascular incident. So we've got some shift in our neurological status, and if that's caused, that's going to cause a shift in our neurological status, and therefore neurological observations would be indicated. Is a DVT? No, a DVT is not related to distributive shock. A DVT is a deep vein thrombosis. This is where we've got a blood clot in a local area and it doesn't have any relationship to shock itself. The signs and symptoms of all 3 are very similar, but there are some subtle differences. So it's about managing the signs and symptoms of shock and looking to see what the clear differences are. Hives is a viral infection, so isn't related to anaphylaxis specifically, but one can become septic from hives. So if you're talking about the swelling that occurs when anaphylaxis occurs, then yes, that can cause distributive shock. Is distributive shock related to a fracture or a sprain? It is a similar reaction when you sprain and your body swells, or part of your body swells. So if, for example, you sprain your ankle and it swells up, that is the same vasodilation occurring. But unless there is a critical shift, you shouldn't go into distributive shock. A fracture might be slightly different because a fracture might cause some internal bleeding and it might cause a dramatic loss in volume. But we are talking about an extreme reaction, and a mild sprain or a sprain in a healthy person wouldn't cause progressive shock. Do you remember when we started the presentation, we talked about compensatory and progressive? If you sprain your ankle, you are going into compensatory shock, yes, but you're not going to go into progressive shock because your body is going to be able to manage the situation and appropriately compensate and prevent you going into progressive shock. Is anaphylactic shock caused by drugs and bee stings? Yes, it is. If you have a rash when you are you have an allergic reaction, that is the body vasodilating. So it goes back to the same answer I gave earlier about compensatory, and it's a compensatory reaction. It doesn't mean that you are going to go into progressive shock. Okay, any other questions? So remember, the body reacts in a specific way. You can prevent it going into progressive shock. While you're still in compensatory shock, your body is managing the situation appropriately. Okay, so we've talked about the stages of shock and we've talked about the classification of shock. So constantly throughout there, I've been talking about patient assessment, and that's going to include observations and measurements. And what I'm talking about there is I'm talking about the observations that we do as nurses, the temperature, the pulse, the blood pressure, oxygen saturations, and so on, but also other measurements. We might look at the size, the shape, the physical presentation. And so that's how we assess our patient. Which one of these types of shock is most fatal? All of them. There isn't a more fatal type of shock. It goes back really to compensatory and progressive shock. All of them are fatal if we don't manage them. Anaphylactic shock can kill us very, very quickly. Equally, septic shock can kill us. Hypovolemic shock, you stab somebody in the stomach, the chances are they're going to die quicker than if they get an infection. It depends whether we manage them. A stroke, so a cerebral vascular incident, can cause neurogenic shock. So yes, a stroke is a type of shock, but we need to be a bit more careful with it. A stroke, so a cerebrovascular incident or a cerebral vascular event, can cause neurogenic shock, so distributive shock. If you suspected that a patient had any kind of neurological deficit or neurological injury, which would include neurogenic shock, then yes, you would do neurological observations. So those would be the additional measurements or observations that we might use if we suspected that a patient was their conscious state, their conscious level was different from how it had been. So very quickly, one of the assessment tools that we use is going to be our ABCDE assessment, where we look at our airway, our breathing, our circulation, our disability, and our exposure. What type of shock did you say a stroke was? Well, a stroke is a cerebral vascular incident or cerebral vascular event, and that would come under the neurogenic shock, distributive shock. What about the prognosis? Well, prognosis is a difficult one to answer, isn't it? Because if we don't manage them appropriately, the prognosis of all of them is pretty poor. And that would also depend on the setting. We are able to manage all types of shock if you're in an emergency department, if you're in a critical care environment. Would you be able to appropriately manage and therefore improve the prognosis of a patient who is hypovolemic in a community setting or in a GP surgery? So I wouldn't necessarily answer the question about prognosis. If we don't manage any one of them successfully, if we don't manage any one of them appropriately, the prognosis is going to be very poor. So I've talked about the different types of observations, the different types of vital signs. So any other questions? Just going to pause for a few minutes, see if you've got any other questions. So a brief recap. We've talked about the body and the fluids inside the body. We've talked about how much there should be and how maintaining an appropriate fluid balance is so vital to our patient care. We then went on to talk about the stages of shock, so how the patients can go into a fight and flight response in compensatory shock. They can go into progressive shock, and if they go into progressive shock, that's when certain signs and symptoms become evident. Then we talked about the different types of shock. So hypovolemic shock, cardiogenic shock, and distributive shock. Some of the questions that are coming in. So how would temperature be affected by the different types of shock? Well, I suppose my answer to that question was yes, they would be. If a patient is hypovolemic, so they're losing a dramatic amount of volume, the chances are they're going to become quite cold. So their temperature would possibly drop. Patient with cardiogenic shock, there wouldn't necessarily be any change in their temperature, their core temperature, because the volume hasn't gone anywhere. In distributive shock, we might have a local raise in temperature. So for example, if the distributive shock was caused by anaphylaxis, the specific area that had swollen might become hot, but our core temperature probably wouldn't change. In terms of septic shock, so a patient who's got distributive shock due to infection, due to septicemia, they can become hypothermic and hyperthermic. So temperature can go up and it can go down. So it depends on the cause and it depends on whereabouts in the trajectory of shock, i.e. are they at the beginning compensating? Are they at the beginning of the progressive stage when the temperature in septic shock tends to go up? But then as the patient goes into further through progressive shock and tissue perfusion decreases, then the patient can become quite cold. So we need to look at what their core temperature is and see how that relates to what's going on in the rest of the body. And temperature measurements, although significant, are less significant than blood pressure and pulse. Septic shock can be caused by an infection or a virus. So septic shock can be caused by either. We often assume it's an infection, but it isn't always. Any other questions? If you are suffering from septic shock, your diastolic measurement will go down dramatically. So yes, you're absolutely right. Diastolic will decrease. But do you remember when we were talking about the subtle changes in the blood pressure? Your diastolic and your systolic will decrease, but your diastolic measurement will decrease more than your systolic measurement has, because your systolic measurement is about the stroke volume and cardiac output, and that hasn't really decreased because your circulating volume is still circulating. But your diastolic is about tissue, is about peripheral resistance, and with vasodilation occurring in progressive distributive shock, then your diastolic measurement will go down dramatically. What's your role as a student nurse anywhere? I suppose I'd change that question. You will be undertaking, in association with your mentor, the observations. So you will be practicing your assessment techniques and undertaking the observations. So when you're reviewing the observation charts of your patients in conjunction with your mentors or other members of staff, look for patterns, look for changes, look for differences, and explore why those changes have occurred. So your role as a first year is to look and listen, but it's about those changes in your assessment and how the different observations that you are undertaking. How long does it take for a body to maintain its equilibrium? Well, that's going to depend on a number of issues, isn't it? It's going to depend on how fit and healthy you were prior to the event. So and this isn't advocating any sort of violence in any way, shape or form, so please don't be offended in any way by this statement. If I had two 5'10", 70-kilogram gentlemen in front of me, and one of them was 20 and the other one was 80, and I stabbed both of them in the stomach, I'm not advocating violence, I would never actually do this. The 20-year-old, if they had no previous medical history, could possibly maintain an equilibrium and therefore maintain compensatory shock for longer than my 80-year-old. If they were both 20, but one had a cardiac condition or a respiratory condition, again, the fit, healthy 20-year-old would last longer, would maintain compensatory shock for longer than the other. So it's going to depend on previous medical history, age, previous levels of fitness, and possibly gender. Men, because they have a slightly higher proportion of body fluid, may be able to maintain compensatory shock for longer than women. So we've got a number of determining factors are going to change the amount of time it takes for the body to react and move from compensatory shock into progressive shock. Okay, any other questions? Okay, if there's no other questions, thank you very much for your attention this morning. I do apologise for the loss of transmission halfway through, and I hope that the recording from the first half has stayed, so I will check the technology in a minute. The presentation, as I said at the beginning, is on the DLE already, the PowerPoint, and there is a supplementary piece of writing that you might find very useful, which gives you some far more detail about management and presentation and pathophysiology of the 3 different types of shocks, the 3 different classifications. So thank you very much. I hope you've enjoyed it, and I hope to virtually see you, or actually see you again soon in the future. Okay, thank you very much.